All right, good afternoon again, everyone. Thank you for being here. My name is Kelly Johnson. I'm the Medical Director for the California Prevention Training Center at the University of California, San Francisco. I am so excited to bring you our STI Expert Hour webinar entitled DoxyPEP 2.0, People Assigned Female Sex at Birth. We are so lucky to have Dr. Jenell Stewart with us here as our expert speaker. So I'll be emceeing today's webinar. I'm going to be going over some introductory slides, some Zoom housekeeping, and then I'll be introducing our speaker. So without further ado, first I'm going to just tell you a little bit more about the California Prevention Training Center, or CAPTC, which is at the University of California, San Francisco. We are a multidisciplinary training and capacity building assistance center. Our STI clinical training is sponsored by the CDC, and we're a member of a national network of prevention training centers. What do we do? Well, we provide virtual and in-person trainings, technical assistance, clinical tools, and STI clinical consultation services. We focus on complex STI issues in patient care. And you can learn more about us, the CAPTC at UCSF, or the national network of which we're a part, by visiting the web pages here on this slide. I do want to highlight one resource. Our CAPTC at UCSF runs the STD Clinical Consultation Network, or STD-CCN, for our region. This is an online clinical consultation network where providers can go submit their complex STI questions, and one of our faculty members, who are subject matter experts, will reply either by phone or email, whichever you prefer, in 1 to 5 business days. Here's our financial disclosure for today's webinar. We have nothing to disclose. And here's our CME disclosure, stating that today's training will be offered at 1.5 or 1.5 CME units at no cost to you. We get a lot of questions about this, so here's what you need to do to earn your 1.5 CME requirements. So you must have registered on the NNPTC site for this webinar by November 8th, and registration is now closed. You do also have to attend today's webinar live and in full. We'll record your attendance as you sign into the webinar. We are unable to issue CME credit for folks who are attending just part of this webinar, or folks who may be listening to a recording of the webinar after the fact. Finally, you also must complete a post-course survey evaluation by our deadline of November 20th. This post-course survey evaluation will be sent to you within 24 hours after today's webinar. You'll get an email with a notification and a link to complete the survey. The email will come from training@nnptc.org, and it will go to the same email address that you used to register for today's webinar. To make sure you get this email, please do add training@nnptc.org to your safe and trusted senders list, and monitor your spam, inbox, and junk folders for this notification. If you do meet our CME requirements, you'll receive CME notification by January 8th of 2025. This notification about your CMEs will come from a different email address. It's captc@ucsf.edu. It will have a link that you can click to claim your certificate from our CME provider, which is the University of Nevada, Reno School of Medicine. The CME notification from us will come again to that same email address that you used to register for today's webinar. And again, please add that captc@ucsf.edu to your safe and trusted senders list, and check those spam and junk folders if you do not get this CME notification. Next, we also get questions about this. So in about 2 weeks after today's webinar, you'll receive the post-course materials. So this will be another email notification. It'll come again from us, captc@ucsf.edu, and it'll have another link that you can use to click on the webinar recording, get your slide handout, and review the CME requirements. You don't need to request any of these materials separately. They will just come to you, again, to that same email address that you used to register. Now, I think most of us are familiar with Zoom at this point, but a couple housekeeping notes for today. The Q&A will be turned on for attendees. The microphone, video, and chat will be off. So to use the Q&A, click on that icon that you see on this slide, which will be on the bottom of your Zoom screen. Once you click on the Q&A icon, you can type in your question and click Send to submit. If you want to send your question anonymously, totally fine, just select Anonymous. You can submit your questions up until the last 2 minutes of the Q&A. Now, during the webinar, I'll be reviewing the Q&A. I may answer your questions directly in the chat, or we may save them to answer live in the Q&A session at the end of today's talk. You can also submit any administrative questions into the Q&A, and our administrative staff, Elizabeth Olson and Lauren Blakely, will respond there as well. If you have any questions, let me go back one. If you have any questions about today's webinar, please reach out to Elizabeth Olson, who is our CAPTC Clinical Program Manager. Her email address is on this slide. Now, finally, I have the absolute pleasure to introduce our STI Expert Hour webinar speaker, Dr. Jenell Stewart. Dr. Stewart is an infectious diseases physician scientist focused on STI and HIV prevention with true expertise on DoxyPEP. She has insights into the only completed study on DoxyPEP among cisgender women, which is the DPEP Kenya study, which she actually led with colleagues at the Kenya Medical Research Institute. Dr. Stewart will also be announcing ongoing and upcoming studies on DoxyPEP for people assigned female at birth. And again, we are so happy and excited to have her here. It should be a great session. I'm going to stop sharing my slides and turn it over to you, Dr. Stewart. Thank you again.
Thank you, Kelly. Bear with me, everyone, while I get my slides up. And thank you, everyone, for being here today. Wow, it's so exciting to see so many people here for this webinar, and people who are thinking about DoxyPEP for people who are assigned female sex at birth. So I'm going to tell you about hot off the press STI trends. The CDC just put out their 2023 data this morning. And you're going to hear a little bit about DPEP mechanism, our DoxyPEP mechanism, make sure you're all familiar with what it is and how it's dosed, the concept behind it. Tell you about the data that exists so far, primarily among people who are assigned male sex at birth and what we can extrapolate from those data, as well as studies among people who are assigned female sex at birth. Talk to you about some exciting ongoing and upcoming studies for people who are assigned female sex at birth, and tell you about some of the DoxyPEP guidelines, although they are growing by the day. Okay, so hot off the press, CDC just announced the surveillance report this morning. And as you can see here in this graph, there are a lot of STIs in the United States. The exciting takeaway here is that there is a very, very slight, around 2% reduction in STIs from last year, which they are suggesting maybe due to DoxyPEP. More will be known as we look at where DoxyPEP is being rolled out, understanding those communities. But exciting to think that we're not just seeing this exponential rise that we were seeing in prior years. That being said, were over 2 million bacterial STIs diagnosed in the United States last year, so still plenty of work to be done to prevent these infections. There's lots to be said about the distribution of bacterial STIs, and I'm going to focus in on sex assigned at birth. And I apologize about the terms of male and female here. I am using what CDC has in their reports, and they are referring to sex that was assigned at birth when they are using the terms male and female. And so the key takeaway here, and I'll go through each of the bacterial STIs, but focusing here first on syphilis, you can see that the rates took a serious dip in the 90s, and they stayed quite low in the early 2000s, and then just increasing rise across both people assigned male sex and female sex at birth. And then just in the last year, you're starting to see that go down a little bit. And that hot pink line, for those of you who see color in the middle of the slide, that is demonstrating this male to female rate ratio. And that is really demonstrating the disproportionate rise among people who are assigned female sex at birth, although you are seeing that come down a little bit in the last year. Looking at chlamydia rates, these are pretty consistently high across people assigned male and female sex at birth. Many more cases among people who are assigned female sex at birth, and that has been true and really consistent parallel lines here over the years. The opposite is true for gonorrhea, where we see more cases among people who are assigned male sex at birth. And here you're starting to see that slight downtrend in the last couple years. All right, so what are we going to do about all of these STIs? There is testing programs, there is expedited partner therapy, there's condoms, but those things have not worked super well in the last decade, and clearly people need more tools in their toolbox. And one exciting way to do that is really individually driven antibiotic prophylaxis. And so I just want to take a step back to think about what we mean by antibiotic prophylaxis. This isn't a new idea. We give out antibiotics to prevent malaria when people are traveling. If you are bitten by a certain type of tick, then you will get a 200 milligram dose of doxycycline to prevent Lyme disease, etc. There's also a growing and now longstanding tradition of giving antivirals to prevent viral infections, specifically HIV, through growing programs of HIV post-exposure prophylaxis, or PEP, and pre-exposure prophylaxis, or PrEP. And then doxycycline, when we think about these bacterial STIs, we have lots of experience with it. We've used it for other forms of prophylaxis, but it is a proven treatment for syphilis. It's our number one treatment for chlamydia right now. And after decades of people using doxycycline to treat syphilis and chlamydia, and also in conjunction where people are being exposed when they have those infections, there are no cases of resistance in those two bacteria to date. So that makes it an ideal option for doing a post-exposure prophylaxis. And when I talk about a post-exposure prophylaxis, what I'm talking about here is really using a quite heteronormative term, a morning after pill. And so you have an exposure, you have condomless sex, and then within 72 hours, you're going to take that 200 milligram dose. So for most people, that's 2 pills of 100 milligrams, and you take that as a single dose. And that's it. This has been studied. I'm going to walk you through several of the studies to date. The initial study was a pilot study done out of LA, Bolin et al. And this one was actually DoxyPEP, meaning 100 milligrams daily, rather than the post-exposure prophylaxis dosing, or DoxyPEP. And in this small study of 30 people who had multiple STIs in the last year, they saw a significant reduction across all 3 bacterial STIs, syphilis, chlamydia, and gonorrhea, with a 73% reduction. One of the things that all these studies are looking at is this changing people's behavior? And we could get into the validity of asking those questions, but I will report out what they reported out, and that there was no difference in terms of people's sexual behavior when they had access to this tool. So then the first randomized controlled trial of DoxyPEP was actually a sub-study within a HIV PrEP study that was being done in France. That was the IPERGAY study, looking at different formulations for HIV PrEP. And within that, they had 232 people, all cisgender men who were having sex with men, and they were randomized 1-to-1 to getting DoxyPEP. And they limited it to no more than 3 doses in a week, or 600 milligrams in a week, which is really interesting because that's not how it's been done in follow-up studies, versus standard of care, just testing and treating every 3 months. And as you can see here in this curve, a dramatic reduction of STIs overall, with a 47% reduction in bacterial STIs. And this was really driven by chlamydia and syphilis, where they measured around 70% reduction in chlamydia and syphilis. And there was no significant reduction in gonorrhea cases in this study, although it did trend towards potentially decreasing the rates of gonorrhea. So in a follow-up, there was the same group in France, Jean-Michel Molina, did a more complicated trial, which I won't go into all the details of, but it was also looking at the meningococcal B vaccine. But focusing in on the DoxyPEP component of this trial, they did a 2-to-1 randomization of DoxyPEP, or that 200 milligrams within 72 hours of sex, compared with standard of care, the testing and treatment every few months. And they saw a dramatic reduction again, even more so than last time, with around 83% reduction in syphilis and chlamydia, and now seeing a statistically significant reduction in gonorrhea, which was a pleasant surprise because we don't treat gonorrhea with doxycycline, and so this really wasn't an expected finding, but nice to see that there was efficacy in reducing those cases, but only a 33% reduction. What about other settings besides France? So in the United States, Annie Lukemeyer at UCSF and Connie Kellum at University of Washington teamed up to do the DoxyPEP study, and they were much more inclusive in their enrollment criteria. This study enrolled cisgender men who have sex with men and transgender women who have sex with men. And this was a status neutral study. They enrolled people who were taking HIV PrEP, like similar studies previously, as well as folks who are living with HIV, which provides important data on ensuring that we understand that this tool might be impactful for people who are also living with HIV and not just limiting it to people who are using PrEP. And here in their trial, they had an overall reduction of 65%, again, largely being driven by large reduction in incident chlamydia and incident syphilis cases, upwards of in the 80s. And then they also saw a reduction in gonorrhea cases at around 55% reduction. And I'll explain a little bit later about why it might be that the rates for reduction are different in France compared to the United States. And then this group has also gone on to do an open label extension of the DoxyPEP trial, meaning that anyone who was in that standard of care group in the original trial was then given access to DoxyPEP. It was no longer ethical to withhold this intervention once they realized that it was working so well and the study had stopped early. So when they offered DoxyPEP to everyone in the standard of care, everyone except for one participant wanted it, demonstrating a high level of interest and enthusiasm for this tool. And you see here a really significant reduction in the overall incidence of STIs per quarter. Here are some great public health data that came out of San Francisco. They were presented at CROI this year, and the San Francisco group noted overall trends. So the trial data is great for looking at an individual level, looking at reductions in these cohorts, but what about looking at an entire city? What about looking at the overall rates? So here on the left half of the screen, you might appreciate a dotted orange line, which is really the trend of what the STI rate looked like for chlamydia on the left, syphilis on the right, and you can see that it was steady and increasing. And then that blue dotted line on the right side of these two figures demonstrates what would have been if that trend continued, so the counterfactual. But instead of seeing that continued trend of high rates or rising rates of syphilis and chlamydia, you see this green line that demonstrates a downward trajectory. And what really separates this pre and post period is when DoxyPEP was introduced. So this is not just looking at people who are being offered DoxyPEP, like in the trial data, but entire networks of people. We're seeing the cases coming down. And that's important to think about when we think about the overall population level impact when we're thinking about how many antibiotics we're actually using when we're using them in a new way as prophylaxis rather than solely reserving them for treatment. Okay, well, what about people who are assigned female sex at birth? That's why we're all here today. So will it work? And a lot of the conversations around people who are assigned female sex at birth, we start thinking about specific sites of exposure. Everyone's sex life is a little different, so let's pay attention to all the different sites of exposure. But here you can see that you achieve, after a 200 milligram dose, or the same dosing as DoxyPEP, really high levels of doxycycline in rectal tissue, vaginal tissue, cervical tissue, and within the urethra. And this is higher than the MIC, or the minimum amount that you need to kill off that pathogen in treatment dosing. And so it is reaching high enough drug levels in all compartments to kill off all three of these pathogens. But what about over time? So if you look at the both the figure on the left shows the rates in those different compartments over time, and then you can see the actual numbers for the number of hours in the bottom right, comparing plasma, rectal secretions, and vaginal secretions. And importantly, what I'm seeing here is that the doxycycline drug levels are above the minimum for here, this is specific to chlamydia, for 4 full days in the majority of cases. You do see those bars on the graph demonstrating that there is some variability between individual people, but for the most part, you are maintaining those really high therapeutic drug levels for 4 full days after dosing. So it should work. So I'd like to give a shout out to my colleagues at the Kenya Medical Research Institute. We organized and ran the DPEP Kenya study with excellent mentorship from Professor Elizabeth Bakusi, Professor Jared Baton. And I'll tell you a little bit about our study. So similar to how the trials were set up in France and the US, we did an open label randomization 1-to-1 of 200 milligrams of doxycycline compared with standard of care or testing and treatment every 3 months. And here we enrolled adult cisgender women, and we limited it to people who are on HIV PrEP. We could not limit it to people who had prior STIs, as had been done in other studies, due to lack of access to regular STI testing in this context in Kenya. But really wanting to make sure that we offered this intervention in Kenya where the rates of STIs are quite high among cisgender women, especially those with a recognized need and are seeking out PrEP care. So unfortunately, as you can see in the graph, especially the top graph, that blue and red line are basically touching into one purple line, demonstrating no difference between those who were assigned to standard of care and those who were assigned to DoxyPEP. Not the outcome we were hoping for. So let's understand why this happened. And it wasn't due to lack of STIs. So in our study, we had high rates of study retention. 95% of those study follow-up visits were completed. We sent out weekly text messages asking people about their sexual behavior and doxycycline dosing, and 82% of those weekly surveys were completed. We did have 44 pregnancies during the study, and that accounted for about 10% of the follow-up time, where we couldn't give people DoxyPEP because per the guidelines, we hold doxycycline during pregnancy, especially during 2nd and 3rd trimester where there aren't data on safety. So what did people tell us about their sexual behavior in those surveys? So these data demonstrate a wide variety of experiences. I think there's a lot of assumption about how much sex people who are assigned female sex at birth are having, and how that may or may not differ from people who are assigned male sex at birth. And in about 28% of our weekly surveys, participants said, yeah, I didn't have any sex this week. So however, when we asked every 3 months, how many partners did you have in the last 3 months? About half the time, people had more than one partner and were reporting higher frequency of sexual activity. I will also note that that participants told us that they stopped taking their HIV PrEP. 13% of the people reported self-discontinuation primarily due to change in relationship and perceived change in risk. We did not have any incident HIV cases in this trial. So to better understand what happened in this study, we ran a analysis of drug levels in hair samples. So we cut hair samples, about 50 to 100 strands hidden in the back of someone's head, and looking at that 1 centimeter segment closest to someone's scalp, we were able to see how much doxycycline was in that 1 centimeter segment, which essentially correlated with about a month of potential doxycycline use. And when we analyzed a subset of 50 randomly selected people, we found that only 29% of those samples, so we looked at 50 people's hair samples across all follow-up time points in the study, and of those 200 samples, only 58 actually had any doxycycline there. And some participants were taking it 1 quarter, but not another quarter. And so summing that all together, when you are taking a step back, it really indicates that about 44% of the people who were assigned DoxyPEP may not have taken any doxycycline. So with low use of doxycycline, it is no surprise that we weren't able to demonstrate efficacy in our study. I think I could jump straight into what next, but I really do want to take a moment to think about why people were not taking those pills, because medicines only work if people take them. And so they really need to fit into people's lives. So my colleagues conducted serial interviews of 40 participants who were assigned doxycycline PEP over the course of the year that they were enrolled. And in those interviews, which happened at 3 different time points, we saw these trends coming up. We saw key themes around side effects, and primarily that was nausea. People were really concerned about the nausea that they had, and when we dug a little deeper, we recognized that a lot of people were taking their doxycycline on an empty stomach, and which really exacerbated their nausea. We also noted key themes around stigma and privacy concerns. People went through great lengths to hide their pills at home, to hide from family and friends and partners, to take their doses, and that really got in the way of getting all of the doses in. There's also just forgetfulness and trying to remember something that you don't do every day, that is on an ongoing, as-needed basis. That can be really hard to remember. And then partner influence. What will my partner say? Will this cause problems in my relationship if someone knows that I'm taking a medicine to prevent an STI? Because the subtext being that you might be worried that they would expose you to an STI. And then there's just some additional logistical challenges. There were some things that helped people remember to take it, but I'm going to focus more on the barriers, since that was the key challenge to seeing some efficacy in this study. So I mentioned that we looked at these qualitative data across the study. And we saw that the themes that came through really varied by how long people had been in the study. And the early experiences were really dominated by side effects. That first dose just didn't go that well. And that really led to a lot of concerns, as well as the stigma and privacy concerns. And that stigma and privacy concern really dominated throughout. And then going to month 12, people are noticing more challenges with forgetfulness, as well as some additional concerns around side effects. At the end of the study, we pulled people together for focus group discussions. After the study had closed, we knew the results of the study, and we sat a group of 35 participants down in 4 separate study groups to talk about their experiences. And again, those key things that came out of the focus groups were side effects. The nausea with taking it on an empty stomach was a really big challenge for a lot of people, as were the social perceptions and stigma concerns. And these data were presented by my colleague Ben Quach in Munich at the IAS conference. If you're interested, you can get a recording of that and see the full data. So what to do? So based on what we learned from our initial trial, what we learned from the qualitative analyses, we really wanted to meet people where they were and improve their experiences. And so to get rid of decision making around when to take it and when not to take it, we thought, can we give it to people less frequently? What about once a week? And if you remember the slide I showed you earlier about the pharmacokinetics and those drug levels, we saw that it was a high drug level for about 4 days for the prevention of chlamydia. And so if you have this high drug level on board for 4 days, and then as it starts to come down, you're dosing again, so you're almost getting that PEP dosing for those last 3 days, you have this combination of PrEP coverage, pre-exposure coverage, and PEP coverage or post-exposure coverage. And if you're just dosing every Monday or whatever your dose day is, it really takes out some of the challenge of remembering and deciding if you need it. It also reduces the number of pills people need to take. And importantly, so in this study, we're doing a follow-up pilot. We're enrolling 50 people that will be able to compare with the standard of care group enrolled in the DPEP Kenya study to evaluate differences in acceptability between the groups, as well as looking at incident STI rates between these two groups. And so to meet people where they are, we are providing direct dosing out of community locations. So at some community pharmacies, people can select which pharmacy they want to come into to get their weekly dose, or we can send a peer navigator out to them to a spot in the community where they want to meet, and the peer navigator will give them their weekly dose. And importantly, that dose comes with a snack to make sure that people aren't taking their doxycycline on an empty stomach. And we are on track to complete enrollment next week. And we'll be following people for 6 months. So stay tuned for results from this small study in the coming year. Okay, we really need efficacy data, and we really need to think beyond just cisgender women. And so I'm excited to tell you about this project that will be launching in early 2025. Cherie Blair at UCLA and I have teamed up as protocol chairs for an ATN, Adolescent Trials Network, and HPTN, HIV Prevention Trials Network study called Foxy-Doxy. And it is going to be a 1-to-1-to-1 randomization of on-demand DoxyPEP, as you know it from the studies as we did in the DPEP Kenya study, versus a weekly DoxyPEP, so 200 milligrams once a week, regardless of sexual exposure, and standard of care, following people every 3 months, testing and treating as we go. We're going to enroll 730 people ages 13 to 29, and we'll be enrolling people who are assigned female sex at birth regardless of their gender, with a real commitment to ensuring that we're enrolling non-binary folks and transmasculine folks. And we're going to be focusing on people who had an STI in the past year. And as you can see here from this map, we have sites all over the United States where we'll be able to enroll at these 12 sites. And similar to prior studies, we'll be following people for 1 year with quarterly testing and treatment, of course. Okay. The one other thing I need to make sure you're aware of is that there has been another study among people assigned female sex at birth. There was a small pilot study that was done out of Japan, and this is really, it's not a trial, but what it was is a group who were taking care of female sex workers, offered those cisgender female sex workers DoxyPEP, so once daily 100 milligrams, and they decided to offer DoxyPEP because of the frequency of sexual exposures in this cohort. and wanting to make sure that they were getting fully covered with ease of dosing when they are regularly sexually active. And in this group of 40 people, so they offered it to, I think, almost 2,000 people, and 40 people said, yes, I want it. And those 40 people were followed closely, and they saw really dramatic reductions in chlamydia, gonorrhea, and syphilis. In fact, there were no incident syphilis cases among those who were taking the DoxyPEP. They also looked at incidents of yeast infections or candidiasis, as well as bacterial vaginosis, and there was no difference between the groups, which is an exciting thing that we'll be monitoring for people with vaginas and front holes who are concerned about potential side effects of taking antibiotic prophylaxis. Again, this is a small study with 40 people, and but I think does provide some reassurance that we're on the right track, that doxycycline prophylaxis would be beneficial for people who are assigned female sex at birth. Okay, so I have given you an update of the data that exists, the key data that exists so far, and there's still some major unanswered questions. We don't know the clinical significance of microbiome impact from doxycycline PEP. We know that taking an antibiotic intermittently is going to disrupt people's microbiome, but will it persist? Will it be of clinical significance? These are things that we don't have answers for at this time point, but I know people are thinking about that. I think we have some reassurance from initial studies, like looking at no increase in yeast infections and some other smaller studies, but we really don't know over the long term, aside from what we know from people who are taking doxycycline regularly for acne treatment, or people taking it while traveling, or for malaria prophylaxis. There are some studies that looked at that, and we can gain from some knowledge from those, but it's hard to really quantify what the clinical significance is of those shifts in the microbiome. The other thing that we're waiting on more data on is how intermittent dosing of doxycycline impacts Mycoplasma genitalium antimicrobial resistance. So the IPERGAY study in France has released some initial data on MGen, or Mycoplasma genitalium, rates among those who are taking DoxyPEP and those not taking DoxyPEP. And they didn't really see a difference, but they had very, very few cases of MGen in that study in France. And so really hard to make any conclusions. But we use doxycycline as part of the treatment for MGen, and we don't regularly screen people for MGen. And so what will that mean when people are intermittently exposed to doxycycline in terms of potential resistance? Keeping in mind that we already don't screen for MGen and people are getting lots of doxycycline for treating syphilis and treating chlamydia, but I do recognize that the shorter 200 milligram doses might have a differing impact on resistance. Another thing we're paying close attention to is, what does this mean for our not so sophisticated syphilis screening test, the RPR, when we have a breakthrough case of syphilis? Maybe that patient who is using DoxyPEP for one partner but not another partner, and so they're still having exposures to DoxyPEP, but they also have a new case of syphilis. What is that antibiotic use going to do to that RPR titer? Will that impact our ability to diagnose people with new syphilis infections? Early data are early. I'm not going to draw any conclusions. I think we're still waiting on further information, but I know that a lot of people in the STI space are thinking a lot about this and wanting to make sure that we are accurately assessing people. So stay tuned for more on that. The other thing that I want to call out is that we really don't have safety data for fetuses. We know that tetracycline, a medicine that is related to doxycycline that we no longer use, binds calcium much more aggressively than doxycycline. And we know that tetracycline can cause teeth discoloration when a fetus is exposed in the third trimester, when those bones are developing. And so and tetracycline exposures in the first trimester are safe. And so we are giving doxycycline to people regardless of whether or not they're on contraceptive. We don't want to control people's bodies and tell them that they have to use contraceptives. But at this point, when we don't have data on doxycycline safety, we are stopping doxycycline after that first trimester. And it would be really nice to have more definitive data on doxycycline safety, especially as we're thinking about congenital syphilis prevention interventions. The other thing I'll call out is that we really don't have data on population level impact of antimicrobial resistance. And I think a lot of people are thinking about antimicrobial resistance. I am an infectious diseases doctor, and I am here telling you about a way to use antibiotics when people don't have infections. That is not a typical thing for an infectious diseases doctor to say, but I think it's about how we use those antibiotics. I'm talking about people who are already getting a lot of antibiotics for treatment, and now we're talking about using it in a different way for prevention. Not talking about people who aren't getting any antibiotics and then suddenly telling them to use DoxyPEP all the time. And so what do we know so far? So out of the DoxyPEP study and the DoxyVac study and a little bit out of the DPEP Kenya study, we have a little bit of data on antimicrobial resistance. So there's Staph aureus in a lot of people's nose, not everyone. And we sometimes use doxycycline to treat Staph aureus infections like skin and soft tissue infections. So wanting to make sure we understand, is DoxyPEP increasing doxycycline resistance in Staph aureus? In the DoxyPEP study, they saw a reduction in colonization, meaning people who showed up in the study with Staph aureus in their nose didn't have it later on in the study. And so we saw a lot of people lose that colonization. The people who didn't lose the colonization are the people who were resistant to their Staph aureus was resistant to doxycycline. I don't know what that means at a population level yet, but I think something that we are watching and monitoring. Within the DoxyVac study, they had really low prevalence of Staph aureus in the nose, and they didn't see any changes in the study. What about gonorrhea? I mentioned that in the study in France, they saw a 33% reduction in incident gonorrhea, whereas in the United States, among people who are assigned male sex at birth, they saw around a 55% reduction. And those differences have to do with the rates of gonococcus resistance in the community. In Kenya, in the DPEP Kenya study, we tested the gonococcus, and 100% of the gonorrhea cases were already resistant to doxycycline using molecular testing methods. And so we don't actually expect much of an impact for DoxyPEP in settings like Kenya, where the rates are really high already. And so what does this mean? It suggests that DoxyPEP may be less protective against gonorrhea strains if it's already resistant. And I think this is also why we need to continue to test people every 3 months, so that even if they're taking their DoxyPEP very well, we might see breakthrough cases of gonorrhea. And you know, there's a lot of limitations to what we know so far. There's been small numbers that have actually been able to be cultured in those studies, and so there's not a lot of true culture data. And then the other thing that makes it really hard to compare is that in the standard of care group, people who are getting treatment for chlamydia or for syphilis when we have penicillin shortages, they're getting doxycycline as well. So how do we really evaluate the impact of intermittent doxycycline use to treatment use? And the answer is over time, in which with larger populations, it's really hard to pull these data out of small numbers of breakthrough cases in these studies. So where are we with the guidelines? So I just talked to you about antimicrobial resistance, and that is a hot topic internationally and really leading a lot of the conversation about what to do with DoxyPEP. The World Health Organization has not put out guidance yet, and they're awaiting further data. And they've mentioned waiting for more data on resistance, antimicrobial resistance, as well as wanting to make sure that they understand the data for people who are assigned female sex at birth, so that they're not putting guidance out that leaves behind a part of the population. We have seen guidelines coming out of Australia, Germany, and France as part of the European group, and they have considerations. It's not a strong recommendation. It's a consideration for DoxyPEP use, and they really focus on men who have sex with men who've had STIs. And some of these guidelines say that they have to have had more than 2 STIs in the last year, really trying to limit the number of people that they're offering DoxyPEP to. In the UK, however, they've taken an anti-DoxyPEP stance, and this was in 2021, and I do expect some updated guidelines from BASH, or the group in the UK. But as of now, they actively discourage DoxyPEP use, and that's really surrounding concerns for antimicrobial resistance. California has been a leader for, and I want to give you all a shout out, for focusing on early equity. And what this meant was that there was a recommendation early that there's a tool that works for preventing STIs and wanting to make sure that people have access to that tool. And so the early California recommendations were focused on cisgender men who have sex with men and transgender women who have sex with men who've had an STI in the past year. So similar to what we saw in the DoxyPEP trial that was carried out in California and Washington. And then they went further to offer shared decision-making to all non-pregnant individuals who were assigned, including people who are assigned female sex at birth, to recognizing that we don't have enough data to actively exclude AFAB. And this has been echoed by the CDC, who put out guidelines just this year. And they did a really great job of ensuring that they are inclusive. And while they recognize that there is limitations in the evidence and insufficient evidence to really make a recommendation to people who are assigned female sex at birth, they recognize that you can use shared decision making, and if you read through the fine print, in making sure that people know that it exists and offering that to a greater group of people. So in summary, DoxyPEP is another tool in your toolbox, and it can be of benefit to those who are at risk of STI exposure. Biomedical interventions are effective if they fit into people's lives and if they take them. So we need to find ways to support people to use these tools, such as DoxyPEP and HIV PrEP. And then early data on individual level suggests that DoxyPEP has a favorable impact on antimicrobial resistance, but we really need to know more about population level data as well. And then finally, people who are assigned female sex at birth may benefit from DoxyPEP, and you should feel empowered to discuss DoxyPEP with them while we are awaiting results of trials. It may not be for everyone, but people should know that it exists. Thank you so much for attending this webinar today, and I am happy to take any questions from folks in the audience. I do see some things popping up in the chat and Q&A.
Yes, Dr. Stewart, thank you. That was such an excellent tour de force, true expert on this topic. Loved starting from the beginning and ending up where we are now. You're getting lots of clapping hands in the chat. Would you mind stopping to share your slides for just a minute? There's one slide about CMEs that I'm supposed to put up that I always forget to do. So I'm just going to do that real quick. And then you're totally right. There's a bunch of questions in the chat, which I will go ahead and start going over with you in just 1 second. Okay, great. All right, so I'm just going to stop start right at the top. And this was actually something, Dr. Stewart, that you and I were talking about like right at the beginning before our webinar even started, which is, can an individual person, somebody, develop resistance if they were taking DoxyPEP on a daily basis? Like, let's say they're having sex every day, they're taking DoxyPEP every day. Are they going to become resistant to DoxyPEP?
That's such a good question. And I think I'm so glad people are asking this about individually and separating that out from population level, because those are two really different concepts. And I think it's hard for me to answer that question because your body is full of all sorts of good bacteria that are supposed to be there. And then there are some pathogens you might be exposed to along the way. And so what we know from what has been monitored so far is that you are unlikely in the short term to develop resistance. But I don't know about the long term. And what I mean by the long term is that there might be specific bacteria in your colon that don't cause you any problem. They just live there. But that if you're being exposed to doxycycline pretty regularly over a long period of time, those bacteria in your colon might become resistant to doxycycline in you as an individual. But what does that mean for your health? I'm not sure. It's, those are just bacteria who hang out in your gut. That being said, the more people who have that will contribute overall to our population level. And that gets into a really mind-boggling math problem for how to think that through, especially when we start to consider things like the agricultural industry that measures doxycycline use in tons. They report tons of doxycycline that are used every year. And that it also plays into that population level, not just the individual level. If there are specific questions about specific bacteria the individuals are worried about, I'd be happy to address that. But I just made up an example of bacteria in your gut like E. coli.
That's a good one. I think Staph aureus is another good one for us ID doctors who might be listening in. But I'm going to give you other questions because there are a lot of them coming in now. Next one is about objective metrics of adherence. Do you know how reliable hair sampling is for doxy adherence?
Yes. So it is not perfect. But when I don't see any doxycycline there at all, it does suggest that, and we believe that we can detect down to a single dose taken within a month. So when I don't detect any doxycycline in those hair samples, I don't think any doses of doxycycline were taken during that month. For upcoming trials, such as the Foxy-Doxy trial, we're going to be looking at plasma or dried blood spots to evaluate doxycycline drug levels in addition to some hair sampling. But I don't know that hair is able to provide they exactly took this many doses. But I think when the big question is, why didn't it work? And we know that there wasn't any doxycycline there, that it's a pretty reliable way of answering that question.
Okay, so no detection equals no doxy, and you believe it. Okay, great.
Yeah.
Since you mentioned it, another question. Is there meaning behind Foxy Doxy? How'd you pick this name for your study?
Shout out to Chase Cannon in Seattle, who came up with that delightful rhyming title. Mostly it rhymes and it sounds fun, but we do have two X's in the Foxy for XX chromosomed youth, so female or XX chromosomed youth.
Oh, okay. Very cute and double meaning. All right, like it. Okay, next question. Was there any mention of change in the occurrence of BV with DoxyPEP in people with vaginas? You mentioned yeast infections, but what about BV?
Yeah, thank you for clarifying. No change in the BV rates. Again, that was a small study of female sex workers in Japan, only 40 people. But during that follow-up time, they had no difference in BV rates.
Okay, great. And also, you said yeast infections, no change.
That's correct.
Okay, this is an interesting one with a global feel to it. So, in Kenya, as you know, doxycycline is commonly used to treat endemic malaria. Was there any consideration about the role that may play in your findings? For example, were patients aware that the same medication is used to treat malaria? Was there any info on people who had been on Doxy in the last 3 to 6 months to treat other conditions before they enrolled in the study? Basically, like, did malaria and use of doxycycline impact your results, affect how people thought about DoxyPEP, or anything else?
Yeah, doxycycline really isn't used as a treatment in sub-Saharan Africa. In Kenya, it's really artesunate treatments for malaria. And so it really wasn't something people were taking for malaria. Often travelers coming from Europe or the United States who travel to the region might choose doxycycline as their prophylaxis for preventing malaria. But it really isn't a part of the commonly used antibiotics among Kenyan participants and community members. Doxycycline is readily available in Kenya and used for a variety of other reasons. People might go to a kiosk and be able to get doxycycline to take for diarrhea, for example. So I don't want to ignore that concept. Doxycycline is readily available, and I think we see that in some of the high level of resistance in the gonococcus that was collected in Kenya.
Okay, important clarification there. Thank you. Here's a question that I also was wondering. Based on the PK data, how did you pick for the DOT study that's going to be starting up in Kenya? How did you pick once weekly instead of twice weekly dosing?
Yeah, great question. So it's really combining the pharmacokinetics with people's lives. So I'll start with people's lives. So twice weekly is really hard to remember and feasibly harder to get people those doses. Once weekly is a lot easier to remember. In terms of the pharmacokinetics, right now what we're doing is someone has no doxycycline in their system. They have condomless sex, and then they take 200 milligrams of doxycycline, and that drug level ramps up and it wipes out the chlamydia that they were exposed to. That's the concept behind a post-exposure prophylaxis. With once weekly dosing, you maintain a high enough drug level for pre-exposure prophylaxis. If you're exposed during those 4 days, then in theory, the chlamydia will be blasted away and you won't get an infection. And then as it comes down, maybe a few chlamydia have a chance to replicate, but then you take that dose again, just as you would have in the DoxyPEP, and you'll have that on board. And so the idea is really minimizing the amount that people need. And that week provides that combination of PEP and PrEP coverage, rather than twice a week, which would be much closer to just PrEP coverage, meaning you maintain those high drug levels for the full week.
I really like that. So it's a combination of pre and post-exposure prophylaxis. That's how
I I personally wanted to call it Doxy Pepper because it's PEP and PrEP, but that was vetoed.
Oh, oh well. Okay, here's an important question. I think that's coming up a lot for a lot of us. Do you currently recommend DoxyPEP for people assigned female at birth? What info do we discuss with them? How are you having these risk-benefit discussions?
Yeah, so I'll give an example of a patient I saw in clinic in the last week, a cisgender woman who sells sex, and she has had, syphilis a couple times and chlamydia and gonococcus several times in the last couple of years, and is just really frustrated. And so when she met me, I wanted to make sure that she knew that this tool existed and that people who are assigned male sex at birth have ready access to this tool. And I explained how it worked and how we prescribe it for men, cisgender men and transgender women, and said, I don't have trial results to guarantee this is going to work for you, but I think it will work. And I would hate for you to not have access to this tool that might be beneficial. Are you interested in taking it? And she said, yes, anything I can do to prevent more STIs sounds great. And so I prescribe her DoxyPEP just the same way I do to my other patients who are assigned male sex at birth.
So you feel pretty comfortable if it's a person who's vulnerable to STI acquisition, assigned female at birth, have the discussion, but okay to prescribe. And I would say that's similar to what I think is being done in my practice setting too, that people are having these risk benefit discussions, but feeling comfortable giving it a try. And you're right, the California DoxyPEP guidelines do give some leniency to take that approach.
Yeah, I mean, and it's all about making sure people are aware of potential options and then not overselling data, that we don't have yet.
Yeah, totally. How about, we get this question a lot too. It's a practical implementation one, but dispensing quality, like quantity, excuse me, like how much doxy do you choose to give people when you're prescribing it?
Yeah, this is an interesting one. I tend to prescribe a 30-day pill bottle. Sorry, 30 pills in a bottle. So that's 15 doses. And some of my patients want monthly refills. Some of them want every 3-month refills. It really depends on someone's sex life and how often they need to dose. And also just the feasibility of carrying medicines around. I don't want doxycycline to expire on them at home, and they're taking that same doxycycline from like 2 years ago. So I don't want to send them out with hundreds of pills. Yeah, so I talk to my patients about it. I say, I'm going to prescribe you 30 pills. That's 15 doses. Does that sound okay to you to start off?
Okay. Do you take a different approach depending on the patient, or is it kind of blanket for everybody?
I usually start with that number and then gauge from them if they're like, oh, I'm definitely gonna need more than that, or oh, that'll be plenty, and I'll ask if they want me to give them fewer so that they have fewer to keep track of or hang on to.
Got it. Okay. Um, how about, do you know of any plans to look at trans men? I know it's a struggle for trans men to get DoxyPEP.
Yeah, so trans men are encouraged and invited to enroll in the Foxy Doxy study once we get going. We really, really do want to ensure that trans men feel comfortable and included in the Foxy Doxy protocol. So many trans men are excluded from research, and it is a real deficit within the sexual health community, just how little we know about trans men and unique health needs and challenges. So Foxy Doxy will be enrolling trans men.
That's great. Thank you for confirming that again. Another question for you, which has also been coming up on our end too at CAPTC, which is people who've been sexually assaulted. Obviously, DoxyPEP has not been studied per se in that scenario, but it seems plausible that it would work in that scenario. What do you think about DoxyPEP after sexual assault?
Yeah, I think DoxyPEP should be considered as a part of sexual assault package. Again, right now it depends on the sex assigned at birth of that person who has unfortunately been assaulted. I think it's an area that is really understudied, and I think we can do a lot to improve the care and the medications and the duration of medications that we give to people after sexual assault. So I don't know that I would recommend updating clinical practice just yet. But I think that there's definitely grounds to overhaul the entire package that's offered to people.
Okay. Here's another one that came up quite a few times that I've been trying to address it in the chat, but I'm gonna give it to you too. If somebody is having sex every single day, do you think they should take DoxyPEP every single day? Or based on the fact that you can wait up to 72 hours, should they take it every other day? Should they take it every third day? What do you think?
I wish I had data on this. It would be really great to know. And I think what it's going to take is really going back and understanding when people had sex, when they took their DoxyPEP, and looking at those breakthrough cases that came out of the studies in France and in the United States. If we're seeing breakthrough cases when someone waited 72 hours, that would change how I counsel the patient. But right now, what I tell people is we don't have data on that dosing, and so I would say it's more likely to work well the sooner you take it. I think that is just what we know about antibiotics and pathogens and how quickly they replicate. But that being said, it might work if you only take it twice a week. It might work if you only take it once a week. I don't know yet. And then there's also the DISCO trial that's enrolling people who are assigned male sex at birth in Canada, and they're going to be comparing DoxyPEP to DoxyPrep. So they'll be comparing the on-demand 200 milligrams after an exposure with a daily 100 milligram dosing. And I think people who are very sexually active, having sex almost every day, I'm not sure yet which is going to be a better plan for you, if it's going to be that daily 100 milligrams, or maybe it's even once a week. I don't have the data yet, but I think an important question to answer.
Yeah, agree. I think we've been just sort of keeping it simple and saying, like, if you're having sex every day, take Doxy every
Yep.
day for the reasons you mentioned, like we think is likely to be most effective in the first
Mhm.
24 hours. And also, like you were saying, lifestyle and like ease of counseling, like telling somebody to remember to take a medication like every other day or every third day might get more
Mhm.
complicated than just
Mhm.
telling them to take it every day or every time they have sex, in case they skip a day on the sex front.
Mhm. And anecdotally, the breakthrough cases I do see among my patients where I'm prescribing DoxyPEP are when they're forgetting doses. And I don't have I don't have them time out exactly how long until they took their next dose for their next encounter. But those breakthrough cases do happen when people are forgetting doses. And so I'm really emphasizing trying to think of it as a morning after medicine.
Yeah, love it. Okay, speaking of different populations in DoxyPEP, there are a couple questions in the Q&A now about what about cis men, so men who were born assigned male at birth and still identify as men. What about cis men having sex with female partners? Where do they fall in all of this?
Yeah, great question. I would absolutely recommend DoxyPEP to a cisgender man who has had an STI in the last year. I think when we're talking about antibiotics, it's about risks and benefits. If you are having sex in a sex network where the rates of STIs are really low, it doesn't make sense for you to be taking an antibiotic when your risk of getting an STI is really low. I don't know the answer to that. And I think part of that might also have to do with some other things that we don't measure very well, like pleasure. If you're really freaked out about getting an STI and that is getting in the way of you having a good sex life, and taking DoxyPEP improves the quality of your sex because you are feeling more confident and you're less concerned about an STI, that's another good reason to give DoxyPEP.
Yeah, makes sense. Okay, there's a couple of different points in the Q&A about side effects in counseling. So one of them, it's a two-part question. One of them is, do you and did you in DPEP talk to patients about interactions with multivitamins, divalent cations, dairy products? Like, was all of that covered?
So my pharmacy colleagues feel compelled to talk about reducing those potential interactions. I think they're really overstated, especially for doxycycline compared with tetracycline. I think when you look at if someone drinks a glass of milk and they take doxycycline, how much of that calcium binding actually decreases the dose available in someone's body, it is so minuscule. But that being said, people did receive that information. That information is in the drug handouts, and almost all pharmacists will give that information. But I personally, when I talk to my patients about it, I do not focus on that.
Okay, fair enough and interesting. All right, another question about drug-drug interactions. I believe this has been debunked, but I will tell you this came up in our setting too. Do you have any concerns or special instructions for patients taking DoxyPEP with regards to birth control interactions or birth control effectiveness?
Yeah, thanks for that question. I mentioned earlier that I had done studies where I didn't require birth control, but certainly we had participants who were on all sorts of hormonal contraceptives, and there are no interactions with doxycycline. The hormonal contraceptives work just as well. The doxycycline doses are going to be just as high. And so no concerns about potential interactions. I don't have data on gender affirming hormones, but I suspect that it will be very similar and that we won't see any decrease in the dose you're receiving of those hormones or of the doxycycline.
Okay, so you're not expecting that to be a big problem.
Nope,
Okay.
at
All
all.
right, I know we're probably getting tight on time. Not too bad, but there are more questions, so I'm just going to keep going and
Okay,
if you're okay, Dr. Stewart, are you all
I'm
right?
fine.
Okay,
I'm
you all
I'm
right?
used to it. There are many
Yeah,
questions around
there are many
DoxyPEP.
questions. Yes, you called it. Okay, this is another question I think that comes up a lot about known exposures to STIs in people who are taking DoxyPEP. So this question is, if a patient took DoxyPEP after sex and then found out that they were exposed to a confirmed case of chlamydia or syphilis or gonorrhea, do you recommend the full epi treatment or prophylactic treatment, or do you recommend testing and use the results to decide about epi treatment? What are you doing?
Yeah, so I separate out syphilis from gonorrhea and chlamydia, and I've heard that many of my colleagues are taking a similar approach. I think syphilis is just so much harder to diagnose and then also track down within the community. And so if someone has a known syphilis exposure, I do offer treatment to syphilis. Compared with chlamydia and gonorrhea, where I might say, you're taking your DoxyPEP, let's just wait and test, and if you happen to have a breakthrough case, we can treat that. And and that, and then you might end up in some shared decision making where someone's like, oh, is gonorrhea I was exposed to? I don't know how much I trust the DoxyPEP. And I'm like, yeah, I'm with you. We can just give you ceftriaxone. But I'd say for the most part, I really think of syphilis quite differently than gonorrhea and chlamydia. Kelly,
Okay.
is that your practice as well?
Syphilis for sure. I think, we're seeing like gonorrhea has sort of had a different story.
Yep.
So for
Yep.
me, like for gonorrhea, I feel like I'm not sure it's gonna work. I would probably favor treating them. Chlamydia, I'd be fine with test and
Mhm.
treat. And I think sites that I'm aware of in San Francisco are doing definitely treat for syphilis and then do same day testing for gonorrhea, chlamydia. And if you can do
Mhm.
that and get a result, use the result of that test to decide about treatment, which I think is a very reasonable approach.
Yeah, I think it depends on when that exposure was, but
Mhm.
yeah, it's great.
Yeah, I realized I forgot about my two-part question around
Oh, yeah.
like side effects, and I have to come back to part two. Part two was about side effects, or we talked about drug-drug interactions or multivitamin type interactions. This one's about nausea vomiting. Um, I've had two patients report profound nausea vomiting after taking the 200 milligram dose. Each of them had previously tolerated 100 milligrams spaced out over the, like at the BID 12-hour dosing. Any thoughts about spacing the dosing out, or do you find that different formulations might be less hard on
Hmm.
the GI tract compared to others?
Yeah, so I definitely prescribe doxycycline hyclate because it is less harsh on the GI tract. And then different doxycyclines have different coatings as well. I don't bother with the name brand long-acting doxycycline and like the post-pyloric release. Mostly, I really just counsel people about making sure that they're having a snack with their doxycycline or taking it with a meal. I think that is by and large the biggest predictor of whether how people feel after that dose. And then I will say that some people who do experience some nausea with that first dose, it does feel a little bit better with subsequent doses. But I do think some people they're going to feel the side effect more than others. And so I think I'm looking forward to seeing results of things like the DISCO trial with the daily 100 dosing, because that might be a better option for some people who are feeling tortured with the 200 milligram dosing.
Fair enough. Okay, practical question. How do we refer people, including trans men, to the Foxy Doxy study?
So unfortunately, the Foxy Doxy study will only be rolled out in our designated study sites. And so people are going to need to be living in those cities. So in the state of California, where I think all of you are, it's just the UCLA site that will be enrolling in the Foxy-Doxy. So if you know trans men, cisgender women, non-binary folks who are assigned female sex at birth in the LA area, once we start enrollment in January, they're welcome to come and screen and hopefully enroll.
Awesome. And I will say, we actually get a pretty national audience at this point. So there may be folks
Okay,
that are
great.
not in California. So there could be some hope for other people too.
Okay, great.
Okay, we're almost at the end here. Next question is, we were kind of talking about the importance of still getting screened and tested for STIs, particularly if you've had an exposure. This question is getting at how DoxyPEP might change people's practices. So this person works in an STI clinic, and their concern is that patients are going to think that because they're taking Doxy, they don't need to come in for testing or treatment if they have an STI exposure. Because chlamydia and gonorrhea can be asymptomatic and DoxyPEP is not 100% preventative, this person's worried that patients may not come in, might feel that they're fine. Just wondering how you counsel patients on, you still need to come in for STI testing, plus minus treatment.
That's a great question. I think a lot of people want this to be like a wonder drug that is like safe sex encapsulated. And I think we need to be really cautious about what it does and what it doesn't do. And so we know that there were 80% reduction in incident chlamydia and syphilis. It's not 100%. And we don't know yet if it's because people miss doses, the timing of those doses, they just stopped taking it. We don't know what those breakthrough cases were about. And so I can't offer people something 100% effective. And so they need to know to come back in. And then with gonorrhea, I really can't do that because it really depends on what your resistance levels are, where you are, or where the person you're having sex with is coming from. And so really emphasizing that we're going to want those every 3-month screenings to make sure that we don't have breakthrough cases. Then the other thing is making sure I tell people what it doesn't prevent. DoxyPEP does not prevent HIV. DoxyPEP does not prevent herpes. DoxyPEP does not prevent Mpox. The list goes on. And so I really want to make sure I'm being really clear that this protects against bacterial STIs. We don't have data about some other things. And so while I know that it does improve people's peace of mind, and I don't want to take that away from them, I do want people to be realistic about what it does and doesn't do.
Fair enough, and very realistic approach. Okay, I don't know the answer to this. I'm curious if you do. Is the prevalence of treatment-resistant gonorrhea in the UK relative to syphilis a good reason for them not to endorse DoxyPEP? We are very concerned about both. So I guess kind of getting at BASH not recommending DoxyPEP, at least so far. Is it because of resistance rates or something else?
That's a great question. I will not speak for BASH and their thinking. Yeah, I think they have just they've been vocal about wanting to know more about resistance, and I think that's fair. I think it's an important topic, and I think the United States and several jurisdictions of the United States have taken the approach of wanting to make sure people have access to an important tool while we sort out some of the finer details, but we know the big picture story already, and that's enough. So just a difference of approach.
Yeah. Okay, Foxy-Doxy questions again. Will you be looking at trichomonas rates in people assigned female?
Yeah, so we will be testing and treating trichomonas as it comes up in the study. Trichomonas is not treated with doxycycline. There's no anticipated impact. There has been an in vitro study that did show some impact of doxycycline on trichomonas. We know doxycycline treats other parasites like malaria, so it's theoretically possible that it will impact doxycycline will impact trichomonas, but we don't know. It's a true, we don't know. So we'll have more to comment on that soon.
Love it. Okay, and we're down between the two of us to one last question. Audience participation question. Are there any volunteer opportunities for people interested in being part of your ongoing or future DoxyPEP studies?
You can certainly reach out to me and thank you for your enthusiasm for this work. My email address is on that last slide, but you can find me at Hennepin Healthcare at University of Minnesota.
Awesome. And we have made it to the end of the Q&A.
All right. Thanks,
I want
Kelly.
to thank you. Of course, thank you so much for being here. This was a really great session. Thank you to the audience. So many of you had wonderful questions. We had awesome participation and turnout today. So again, Dr. Stewart, we loved having you, and best of luck with all of your upcoming studies.
Thank you. Thanks,
All right,
everyone.